This is Dr. Feast Price, and I will be providing your lecture on Diagnostic and Statistical Manual. This lecture will provide you with an overview of how the DSM is used and how it functions with working with persons with various forms of disabilities and abnormalities. In order to have a thorough picture of the DSM and how it's used, it's important that we understand abnormal behavior. Unlike the International Classification of Functioning, Disability, and Health, the ICF, the DSM focuses on one's abnormal behaviors. And so it looks at how one is functioning from a deficit perspective rather than from their functional perspective. So with looking at abnormal behavior, what we're primarily focused on is the extent to which an individual is conforming to the norms of functional behavior. So we're exploring statistical infrequencies or violations of social norms. It's also based upon a subjective perspective of one's distress. So when we speak of subjectivity, it's looking at the extent to which an individual will identify ways in which they are experiencing distress in their functioning. So it's from one's personal frame of reference or their personal perspective. It also looks at disability or dysfunction. The DSM, as I stated a little bit ago, it focuses on the extent to which one is experiencing dysfunction or abnormal behavior. So as we explore abnormal behavior, we look at it from a normative, evaluative perspective of human behavior. And in so doing, we're looking at a person's behavior as from the extent to which it's abnormal and also whether it's statistically infrequent or frequent. So with the DSM, there is the desire to explore one's behavior, but not just from a clearly subjective frame of reference. However, that is relevant, allowing an individual to give their own personal experiences about the ways in which they're experiencing whatever the shortcomings are. But it's looking at the extent to which it's statistically infrequent or frequency as well, and whether it's significant. It also explores a person's behavior as it relates to abnormal or unusual functioning. So if you think about a person that is normal, whatever normal is, and so one might argue that normalcy is very subjective, but we can also agree that the ways in which we function as human beings fits within a normal frame of reference. And when persons deviate from that normal way of functioning and behaving, one of the things we want to explore, particularly as mental health treatment providers, is how much does a person deviate from what is normal? And so the DSM provides us with an excellent opportunity to examine the extent to which a person is functioning abnormally or different from the norms of the way people typically behave. Whenever you look at one's behavior from a normative perspective or from a statistical frequency or infrequency perspective, there are certain advantages and disadvantages. One of the advantages is there are cutoff points that are used quantitatively to say if certain things occur X number of times, then that will give us a certain range of functioning. So it gives us certain cutoffs by which we can understand a person's behavior. Like if a person does certain behaviors or experiences certain behaviors X number of times, then it's perceived as being abnormal or dysfunctional. Along with that comes certain disadvantages, because we realize as clinicians that there are a few guidelines for establishing cutoff scores. So it's a subjective process. And when you look at subjectivity, one can evaluate a person's behavior as being abnormal when in fact it may not be abnormal at all, particularly when you look at one's behavior from a cultural context. You can't just understand a person's behavior without exploring the cultural context, the environment that they were reared, and various other nuances particular to that individual. And so when you look at cutoff points, it doesn't take into focus some of the nuances associated with culture, some of the nuances as it relates to one's race or ethnicity or environmental factors. Another advantage of a normative or statistical infrequency violation of social norms is that we use social norms as obvious and as intuitive. So you look at one's behavior, and let's say a person is talking extremely fast. They're seem very preoccupied. They are not making coherent sentences. Then we look at their behavior and we make an intuitive judgment about whether or not what the person is communicating in the manner in such to determine whether it's normal or abnormal. But again, as we said before, there are cultural values that play into it, so we have to make sure that when we look at individuals and we determine the extent to which their behavior is normal or abnormal, that we're also focusing on cultural relevance. We are looking at how much deviation there is, and it's important to use specific clear-cut guidelines, but therein lies some of the disadvantages of using the more normative approach because, as we all know, it's all relative. What might appear normal to some people might be abnormal to others, especially when we're not taking into consideration cultural nuances associated with the person. So again, some of the advantages of looking at one's behavior from a conformity to norms or statistical infrequency of social norms. Some of the advantages relate to cutoff points, which are quantitative in nature. It also focuses on social norms that seem to be obvious and have intuitive appeal. But, however, there are also certain disadvantages that relate to the fact that there are a few guidelines that establish cutoff scores. There are a number of deviations when you look at behaviors, particularly when you look at geography, when you look at cultural kinds of issues, socioeconomic variables. So there are the differences that cannot always be understood based upon social norms because we recognize that there's a lot of variability. So when we talk about subjective distress, we're looking at a person's behaviors or symptoms, and we're determining the extent to which they are abnormal, and we're also trying to understand what are the causes of a person's distress. So with subjective distress, when you think about some of the advantages and disadvantages, one of the advantages is that individuals who may be under distress on the inside, but they may not show distress on the outside. And so you can't always tell by looking. For me, I am one of those that have I have stage fright when I have to present in front of an audience, particularly a large audience. And people will oftentimes say to me, "Oh, you look so calm and collected, and you seem like this is such a breeze." But in the inside, my stomach is doing somersaults. I'm sometimes nervous to the extent of nausea. But just looking on the outside, you cannot tell. And so there are times when individuals may be experiencing distress on the inside, but it may not be conveyed on the outside. So it's important to identify what those issues of distress are, particularly from the individual, asking them their frame of reference. Tell me how you're feeling. Tell me how many days you experience trouble getting out of bed, or how many times you cry frequently during the day, because as clinicians, we observe and measure from observations from what is communicated. But we recognize with subjective distress that you have to allow the individual to give their own perspective on what they're experiencing and feeling. But along with understanding things from a subjective reality, we know that there are disadvantages as well. So not all pathology causes distress. For example, conduct disorders and psychoses may not always have internal kinds of abnormalities. Currently, I'm working with someone that has paranoid schizophrenia, and one of the things that he says to me is that the voices that he has in his head oftentimes serves a real purpose for him. And so if you're trying to get a person to convey what their problems are, and we might see it as a pathology, but from the individual's subjective frame of reference, they might not see it as a pathology at all. They might see it as a normal way of coping and functioning. And the same can be said with conduct disorder. Another disadvantage as it relates to subjective distress is the fact that there is sometimes difficulty in determining the amount of subjective distress, and so that it's far more difficult for us to label that distress. So you take two people and you put them in the same room and you ask them to explain their symptoms, and one person might explain their symptoms in one way, another person might describe the exact same symptoms a totally different way. So we recognize that with subjectivity there is a lot of variation and deviation, and so sometimes just the ways in which a person communicates their subjective reality might differ from one person to the other. So dysfunctionality versus disability. And one of the things that's important to keep in mind, particularly since you have already reviewed the ICF, and I'm assuming by now you have a thorough understanding about the ways in which the International Classification of Functioning, Disability, and Health, also referred to as the ICF, is used. And so now we're really highlighting how the DSM is used. And so what's important here is that the ICF focuses on disability and one's functional ability despite whatever their functional limitations are. And that's really key to who we are as rehabilitation counselors. Despite whatever the functional limitations, we as rehabilitation counselors work with clients or consumers to reach their maximum level of functioning. We're not focused on their limitations so much as we are their functional abilities. However, with the DSM, it looks more at one's abnormalities or dysfunctions, and to a far lesser extent to one's functional capabilities. So a behavior is abnormal if it creates some degree of social, interpersonal, or occupational problems. And so it's looking at the ways in which a person is limited rather than the abilities one might have despite their limitations. So there are certain advantages and disadvantages when you focus on disability or dysfunctionality. Certain advantages are that it requires little inference. When you're focusing on one's dysfunctionality, then basically there's little inference that's relevant to dysfunctionality. However, when you're looking at one's abilities, it focuses on the types of problems that often prompt treatment seeking. So with the DSM, you're looking at problem behavior that would cause an individual to seek treatment. Oftentimes, as mental health clinicians, we see clients, when they come in for treatment, it's not because things are going great. Oftentimes, there are certain problems that one might focus on that bring them in for treatment. And so there's the focus on the problems so that you can find the optimal means by which to eliminate or minimize the problems. Some of the disadvantages associated with the focus on disability is that our dysfunctionality has to do with establishing standards for occupational and social functions. If you're only focused on dysfunction, then it's more difficult to focus on ways of improving one's behavior. But if you focus on functionality and the ways in which a person is functioning despite their disability or their limitations, then it's easier to establish standards. It's easier to assist the individual to maximize their potential. So the argument here is that when you focus on dysfunctionality or disability, there is more of a likelihood that the information you get doesn't provide you with what is needed to help a person maximize their functional potential, because after all, you're focused on the dysfunctionality rather than the functionality. So at this point of our discussion, we'll segue into a greater understanding of the DSM, particularly the DSM-4 TR. And so what is important to recognize is that the DSM manual, the Diagnostic and Statistical Manual, is the most widely accepted definition used to describe behavioral, emotional, or cognitive dysfunctions that are unexpected in one's culture, as well as it relates to one's personal distress or substantial impairment in functioning. So yes, the DSM, particularly in the United States, is the most widely used manual for providing information on behavioral, emotional, cognitive functioning. And it also over the years, it has taken more into consideration cultural nuances that are associated with personal distress and impairment in functioning. So as we explore what the DSM is and its evolution over the years, as well as the ICF, one of the things we know is that the ICF has been around for a very long time, even though I feel from my experience as a clinician, it's only now that it's being talked about more and used far more frequently here in the United States. So in 1948, the World Health Organization added a section on classification of mental disorders to the International Classification of Diseases and Health-Related Problems. And they came up with the ICD-10, which is the current system that was developed in 1990. So even though the DSM has been used it's far more commonly used in the United States, the ICF has been in existence far longer, dating back to 1948. It is more widely used in other countries, hence it has more of a world health perspective rather than the functioning or dysfunctionality that one oftentimes relate to in the United States. As it relates to the DSM, it was established in 1952 by the American Psychiatric Association, and it was developed and published initially as a diagnostic and statistical manual for psychiatrists that are working with persons with various forms of mental illness. It was initially published in 2000. The DSM-4 TR was published in its current form in 2000. And so we'll take a look at the genesis and the evolution of the DSM over the years. So back in 1952 was the beginning or the genesis of the DSM. It was a glossary of descriptions of 60 diagnostic categories. However, in 1968, the DSM-2 came on the scene, and it expanded the list that was once 60 diagnostic categories to 145 categories. But it was also very similar to the first manual in terms of its format. Several years later, in 1980, there was the expanded version of the DSM, and the DSM-3 was introduced, and it had many important changes that we'll be discussing further in the next slide. But then in 1994 was the DSM-4, and then in 2000 there were revisions to the DSM-4. Currently, they're working on the DSM-5, which is expected to come out in the year 2013. So as we explore the DSM-3 and the DSM-3R, there are some of the changes that occurred between the DSM-3 and the DSM-3R are that it wasn't based on a specific theoretical framework. So the DSM-3 did not have a theoretical basis to much of what was espoused. And so with the DSM-3R, they brought about more theoretical frameworks by which to understand human behavior. Also, with some of the changes, they presented explicit diagnostic criteria. So whereas before some of the criteria were not as explicit, which left a lot of subjectivity, with the DSM-3R, there were far more explicit diagnostic criteria by which clinicians can understand and conceptualize a person's behavior or deficits or limitations. Additionally, with the DSM-3R, it became more of a multi-axis system, which is what we use today, the axis 1, 2, 3, and 4. And so we'll talk a little bit later about the multi-axis system. Additionally, the specificity of diagnostic criteria made it possible for clinicians to examine the reliability and validity of diagnostic categories. It is very important for clinicians to make sure that when they're making reference to particular behavior, that there is a certain level of reliability across clinicians, as well as validity that says that what we're measuring is actually real and valid, and so that clinician A and clinician B will look at certain behaviors and identify those behaviors consistently, because the information that they are using is reliable and it's valid for the same kinds of clients with similar kinds of characteristics. So when we talk about a multi-axis system, we're communicating, number one, that it's a clinical syndrome that the individual is experiencing, that there are certain personality disorders or developmental disorders that are related to those issues, which relates to axis 2 diagnoses. With the axis 3 diagnoses, it focuses more on physical kinds of conditions, for example, diabetes, HIV, spinal cord injury. So axis 3 focuses on more physiological kinds of symptoms. Axis 4 looks at severity of psychosocial stressors, because we realize that the ways in which a person's mental health are impacted has a lot to do with their psychosocial experiences and stressors. Axis 5 is the highest level of adaptive functioning in the past year, so it gives attention to one's functioning, and it's their global assessment of adaptive functioning over the past year. So with the DSM-3, while there were much improvements in the system, there are also some shortcomings that were apparent. Basically, what was determined was that the acceptability had low reliability in some diagnostic categories in comparison to others. Also, the hierarchical diagnostic system was deemed problematic for some individuals, because what it suggested was that individuals that had higher diagnostic scores were deemed to be more pathological than others. And so with that hierarchical system, it is believed that while it's important to assess one's functional limitations, it's less productive to see persons as more hierarchically significant and problematic in terms of their functioning potential or functional limitations. However, with the DSM-3R, which was published in 1987, it eliminated the problems associated with the hierarchical diagnoses. It's important to understand the problems without labeling a person as being most profound or or least profound, but yet it speaks to some of the problems or limitations associated with their functioning. So with the DSM-4 and the DSM-4-TR, the DSM-4 came about in 1994. Some of the revisions were based upon additional empirical data that was generated by the DSM-3 and the DSM-3R. It reorganized the DSM axes 4 and 5. So axis 4 ratings pertain to the severity of stressors that was changed to a checklist. And also for axis 5, it was changed to the GAF, the Global Assessment of Functioning Scale, whereas before that did not, there wasn't the assessment of the global functioning. Number one, if a person marks 1 on the GAF, they had a GAF score of 1, it shows that the person was markedly poorly functioning. However, a score of 90 indicated that persons are functioning far more superior in comparison to others, so superior functioning. With the DSM-4-TR, there were minimal changes. However, the changes that did take place were specific to the descriptions of some of the disorders that were in place previously. So, as we look at the evolution of the DSM as it relates to the number of diagnostic categories, one of the things we'll find is that the DSM-1 had 106 categories. The DSM-2 had 182 categories, 265 categories for the DSM-3, 292 categories for the DSM-3R, and the DSM-4-TR has 297 categories. So as you could see over the years, the American Psychiatric Association has been making great strides in further understanding and identifying DSM categories that are most relevant to persons with various forms of mental illness. There is a great deal of research that goes into understanding and operationalizing all forms of illnesses. And I really like and appreciate that every year, with every iteration of the DSM, more and more attention is being given to understanding one's behavior or abnormal behavior, and trying to better understand how to assess and operationalize behavior so that it is very systematized and relevant for individuals, as well as reliable and valid. So they're in the business of trying to make sure that they get it right when persons are diagnosed with a particular kind of disability, and that it's not, in fact, other kinds of issues that are impacting one's functioning or abnormalities in functioning. So as it relates to the DSM and how issues, or how the diagnostic categories come about, it's as a result of an enormous amount of literature reviews, combing through the literature, understanding behavior changes, understanding issues from a cultural perspective, various kinds of issues that must be taken into consideration. So the body that looks at these various diagnostic categories, they don't arrive at these diagnostic changes lightly. They definitely take into consideration the literature that exists out there, that's based upon data that has been collected, empirically validated studies, as well as various forms of research to best understand behavior, operationalize the behavior, and come about diagnostic categories that are empirically based and empirically sound. And so the DSM categories take into consideration field trials. So field trials are when clinicians are actually out in the field. They are working in various forms of inpatient and outpatient treatment facilities, attempting to best understand what the diagnostic criteria are, ways in which the criteria must be refined or reevaluated so that they can ensure that consumers or clients that might be diagnosed as paranoid schizophrenia will have a valid diagnosis, and that diagnostic criteria would be consistent for individuals that are from various cultural backgrounds, as well as those that reside in various geographical locations. There was a time when the DSM, especially with its initial iterations, when it would pathologize persons based upon issues that are more indicative of cultural values or racial, ethnic kinds of issues, geographical boundaries. And so with the various iterations of the DSM, more consideration has been given to ensuring that persons that are diagnosed with a particular kind of clinical diagnosis or personality disorder, or consistent irrespective of racial or ethnic issues, geographical locations, socioeconomic kinds of variables, but that it's consistent across the board. So the DSM-4TR clearly reflects the importance of research to differentiate the diagnostic categories, and with more and more research that's being done, particularly for the DSM-5, additional effort has been given to looking at literature reviews, data analysis, and reanalysis, as well as field trials, attempting to get it right and perfect the science associated with diagnostic and statistical measurement of mental functioning. So I've made reference to the DSM-5 that will be coming on the scene next year, and in an effort to ensure that the DSM has further reached its mark of proficiency and excellence, they started with 13 work groups that vigorously explored all of the different aspects of the DSM. They also had task forces of 27 members in overseeing the process to make sure that there was a voice that was heard for all of the critical issues relevant to the DSM. And in addition, they allowed the public to have an opportunity to look at various aspects of the DSM and to provide feedback and input associated with it. So it shows that there is definitely a consumer-oriented perspective, because there is much value not only from professionals but also from the public to give their perspective on the DSM, because these, it's actual lives that are directly connected with the DSM and the categories that come about as it relates to the DSM. And so I really have an appreciation for the level of intensity and work that goes into making sure that the needs and the voices are heard, and careful attention is given to ensuring that persons with various forms of mental illness and persons that are concerned about these issues are given voice, and those voices are taken into consideration with the next iteration of the DSM. I can remember a time when persons that might be gay or lesbian in the DSM were pathologized and perceived as having a disability because of their sexual orientation. And it's only through research and through better understanding issues that definitions have evolved, and persons are not pathologized because of issues related to sexual orientation or even racial ethnic kinds of issues, but that they are making sure that they understand and giving sensitivity to these issues, and making sure that mental illnesses speak accurately to disabilities or dysfunctions, and not pathologizing behaviors based upon a lack of knowledge and evidence. So in terms of some of the suggested changes for the DSM-5, they're exploring the possibility of eliminating axes 1, 2, and 3. They're also exploring the use of a dimensional system where various disorders will be coded as mild, moderate, and severe. They're looking at introducing new suicide assessment scales, having one specific to adolescents and another one specific to adults. There are several new disorders that will be proposed and some name changes that will be incorporated as it relates to some of the existing disorders. Additionally, personality disorders will be completely restructured and better operationalized. So with regard to the DSM-4 and areas for further study, there will be an appendix for behavioral addictions. We understand now more than ever before that persons are having addictions to gambling that heretofore were not clearly explained and operationalized within the DSM. So there is far more information that will be specific to gambling disorders. Now with the internet and having far more information at our fingertips, it's coming to bear that there are far more internet addictions. So this means that this is another particular area that is being considered for incorporation into the DSM-5. And in addition to that, they're introducing a new section on suicide scales to help assess adults and adolescents. So similar to what was communicated on the previous slides. There's new risk syndromes that are that is a category designed to help clinicians identify stages of some of the more serious forms of mental health disorders. And so what is provided will be what will be provided are scales that include research-based criteria by which to better understand risk syndromes. So as it relates to diagnosis, there are certain positive aspects associated with diagnosis. It facilitates communication. It allows for verbal shorthand. For example, rather than having to write out everything associated with an Axis 1 diagnosis, whenever we say Axis 1, we always know that it refers to different forms of clinical kinds of assessments or clinical science types of disorders, schizophrenia, as well as other forms of Axis 1 diagnoses that we'll be talking about in greater detail. It also ensures comparability among identified patients, so that if we're talking about schizophrenia, various forms of schizophrenia, what schizophrenia might look like with one client would also be consistent with another client. And so it ensures that there is comparability across patients. And it also promotes research on diagnostic features, the etiology, as well as the treatment associated with a particular mental health diagnosis. So with every positive, we recognize that there are also negative aspects associated with a diagnosis category associated with the DSM. And so we know that there are boundaries that exist between disorders that are sometimes fuzzy. It's not clearly understood and explained. There are sometimes gender biases in the application associated with certain diagnostic labels. And we also know that there are times when there are negative effects of labeling that is associated with one's perception. So if a person is diagnosed as having a certain kind of Axis 1 diagnosis or schizophrenia, it conjures up certain perceptions for an individual. And so along with all the benefits associated with having a specific diagnostic diagnosis, there are certain labels, that negative labels, as it relates to one's perception of a particular diagnosis. And with negative labeling comes a negative self-concept. And when persons feel negatively about a label that they're given, then sometimes there's the likelihood that persons are unwilling to accept a particular diagnosis. And so when they're not accepting of their diagnosis, then they're also not willing to accept the prescribed treatment. So oftentimes when I work with clients that have DSM labels, rather than focusing on the label itself, I focus on the functional abilities as well as limitations associated with the diagnosis, helping to diminish the level of stigma associated with the disability or with the diagnosis. So as it relates to gender biases in diagnosis, we know that the gender of the patient may have an influence on the diagnosis despite the presentation of equivalent symptoms in others. So we know that with females particularly, they're far more likely to be identified with depressed symptoms. And for males, for example, they are less likely to be identified as having depressive symptoms because there are not always a clear delineation of how certain kinds of mental illnesses manifest themselves in males in comparison to females. And depression is among those that have clearly defined differences, not only in terms of the way in which they're defined, but also the way in which they're understood and identified in males and females. So just to further elaborate on the multi-axis system that is specific to the DSM, we want to just kind of unpack that and further understand it in greater detail. So we mentioned before that the DSM, particularly the DSM-4TR, has 5 diagnostic axes, and axis 1 relates to clinical disorders and other conditions that may be a focus of clinical attention. Axis 2 relates to personality disorders and mental retardation. Axis 3 relates to general medical conditions. Axis 4 has a focus on psychosocial and environmental problems. And Axis 5 looks at global assessment of functioning. So just to further unpack Axis 1, which relates to clinical disorders and as well as other conditions that may be a focus of clinical attention, we know that it deals with all of the various disorders except personality disorders and mental retardation. If more than one Axis 1 diagnosis exists, it should be reported. And it's best to also label what the principal diagnosis is, or reasons for visit. So we want to make sure that we know that, first of all, a person can have multiple Axis 1 diagnoses, but we want to identify what the principal diagnosis is, or what the key diagnosis that has resulted in a person coming in for treatment. If more information is needed to make an Axis 1 diagnosis, it is coded as deferred, and the code that is used is 799.9. If no Axis 1 diagnosis is warranted, it would be coded as none, or V71.09. With regard to Axis 2 diagnoses, which relates to personality disorders and mental retardation, Axis 2 notes prominent maladaptive personality features and defense mechanisms. It has a separate axis for these concerns so that we can ensure that consideration is given to the possible presence of personality disorders and mental retardation. Previously, it was determined that without separating maladaptive personality features and mental retardation from clinical diagnosis, that oftentimes they would go overlooked because more attention was given to the Axis 1 disorder. Hence, the Axis 2 disorders came about to give further attention to personality disorders as well as mental retardation. It's important to note that borderline intellectual functioning is also coded on Axis 2 rather than Axis 1. Even if Axis 1 diagnoses are more florid, more pronounced, Axis 2 diagnoses are also equally important. And so that is one of the primary reasons why Axis 2 was developed, so that personality kinds of issues as well as mental retardation could be given more attention, because otherwise it was being lost due to some of the more Axis 1 diagnoses. So if more information is needed to make an Axis 1 diagnosis, as we stated before, it would be for Axis 1 as well as Axis 2, I think it would be 799.9, as well as for if none is warranted. So as it relates to the severity of the impairment for both Axis 1 and Axis 2, it an individual, a clinician, can code the severity in some diagnostic categories. For example, with mental retardation, you would identify whether it's mild, moderate, severe, or profound. And so you would use the various diagnostic categories identified below as it pertains to mild, moderate, and severe. It also can be noted that with Axis 1 or Axis 2 that persons can be in either partial or full remission, as well as the importance of having a prior history of having an Axis 1 or Axis 2 diagnosis despite the remission that might have occurred. It gives notice to whether or not the person has ever had a history of such a disorder. So it also provides an opportunity to rule out various forms of impairments or disabilities. And suppose you assess a patient and believe that a diagnosis is warranted, however, you don't have the necessary information to confirm the diagnosis. However, you also have a hunch to not diagnose. This hunch would not communicate the clear clinical picture of the person. So when such is the case, then you may consider using a rule-out diagnosis in place of the actual diagnosis. So you don't have enough information, but you don't want to rule it out totally because you have a hunch that it can potentially exist. And so you would want to use a rule-out diagnosis rather than the actual diagnosis, or omitting the diagnosis altogether. So with Axis 3 diagnoses, it's pertaining to general medical conditions, and these should be potentially relevant to understanding our management of the individual's mental disorder. We know that there are times a person may have, for example, AIDS, and along with AIDS might come certain kinds of other Axis diagnoses. They might have an Axis 1 diagnosis that is specific to a general medical condition. So when that is the case, then you want to make sure that you include what the Axis 3 disorder is in order to better understand what the Axis 1 disorder is. And so the primary purpose of an Axis 3 is to encourage thoroughness in the evaluation, to give more of a total picture or gestalt of what the person is going through. And it also enhanced the communication among healthcare providers so that one provider isn't understanding one's diagnosis from one perspective without giving total attention and consideration to the fact that there might be some medical issues or medical kinds of conditions that might contribute or be the cause of an Axis 1 or an Axis 2 diagnosis. Persons may have differential diagnostic issues. So if a general medical condition is a direct pathologic cause of a mental disorder, it is coded on Axis 1 and Axis 3. So the example here is you might have an Axis 1 mood disorder due to hypothyroidism. And also with Axis 3, you would indicate what the medical condition is. So then it would have hypothyroidism listed under Axis 3, as well as some of the manifestations as it pertains to Axis 1. So in addition, with the Axis 3 general medical conditions, it relates to medical conditions that can be influenced by psychotherapy, by pharmacotherapy, so medications. So there are times when medical conditions can influence one's choice in the kind of psychopharmacology that would be best used for treating the individual. It also has important information as it relates to coding what the person's diagnostic issues are. So if multiple diagnoses are present on axis 3, you would want to make sure that you code all of the different medical conditions that are relevant. If no diagnosis is present, then you would code it as none. Of particular note here is that there are numerical codes for axis 3 that comes directly from the ICF-9 or the ICF-10. So no numerical code would be reflected as none. So with axis 4, which pertains to psychosocial and environmental problems, it takes into consideration more of a biopsychosocial perspective as it relates to the individual. So not only does it look at axis 3 and axis 1, axis 2, and axis 4, but it takes it all together and it looks at what some of the psychosocial and environmental barriers or implications are. And these are typically a negative life event, an environmental difficulty or deficiency, or familial or interpersonal stressor, poor social support, or personal resources, all of which that may contribute to a person's axis 1 through 4 diagnoses. So one of the things that is important here, even for us as clinicians, is that you cannot understand an individual without also taking into consideration some of the biopsychosocial as well as environmental factors that are very relevant. Because to not give this particular area consideration means that you can misdiagnose or mistreat an individual due to some of their environmental or psychosocial issues. So here are examples of some of the psychosocial and environmental problems that would be reflected in the DSM-4. The individual may have problems with their primary support group. There could possibly be a death of a family member. There might be problems related to the social environment. For example, difficulty with acculturation or difficulty adjusting to a new environment. There may also be educational problems, for example, discord between students and their teachers, as well as occupational kinds of problems. Unemployment, for example, would be a major issue that would be reflected in the DSM under axis 4 of the DSM as it relates to the individual. Additional examples includes homeless problems or homelessness, economic problems or insufficient social support services to maintain one's daily living, problems with access to health care services or inadequate health insurance would also relate to the DSM-4. Relate to the axis 4 of the DSM. Problems related to interactions with legal system or incarceration, that too would be relevant as to one's axis 4 diagnosis, as well as other psychosocial and environmental issues. For example, whether there's a war that's going on, a natural disaster, all of these issues would also be relevant to one's diagnosis and understanding the extent to which their mental health is being impacted. So it gives a gestalt. It takes every facet of the individual into consideration, not leaving out anything, whether it be medical, psychosocial, environmental, various forms of clinical issues, whether it be depression or schizophrenia, as well as personality disorders and mental retardation. As it relates to axis 5, the global assessment of functioning, it has to do with a clinician's clinical judgment. that's associated with their functioning. So the question that is asked is, how is the patient doing overall? How are they functioning in light of issues that relate excuse me, that as it relates to issues relevant to their clinical functioning, any problems with personality, medical issues, psychosocial or environmental functioning. How is the person functioning in their daily existence? It's rated on a global assessment scale, and it is based upon a 100-point scale that is divided into 10 ranges. There is also a GAF score for children, which is known as Children's Global Assessment Scale, adapted for children. And it can also report the time period that the rating encompasses. For example, it can be current, it can have highest, which is over the past year, the time at the way in which a person is functioning at admission, as well as the way in which they're functioning at discharge. So all of these key points are most relevant to the functioning of an individual. So basically, I have prepared you with a lot of invaluable information by which to understand the DSM for persons that are interested in working in various treatment settings, whether it be an inpatient setting or an outpatient setting, whether it's the ambitions of working in your own private practice. It's really, really important that you understand the DSM, that you have a copy of the Diagnostic and Statistical Manual that's required, which is one of the required textbooks for this course. There are various kinds of handy abbreviated or pocket-size manuals that you can use, but it's really one of those key pieces of informations that you will always use. For me on my iPhone, I always have easy accessible information specific to the DSM. It's impossible to know all of this information. What you might find is that as you use the DSM more and more, there are certain categories that you might use far more frequently, but it is important that you have a very good working knowledge of how to use the DSM, and this lecture was geared to provide you with an overview of the DSM from its genesis to where it is today and to where it will be to next year when the DSM-5 comes about, and also to give you a conceptual framework by which to understand the evolution of the DSM, the amount of time, effort, and research that has gone in, and how we as clinicians must give a lot of time and consideration to not only diagnosing individuals, but taking into consideration all issues that are relevant to the person, understanding them from a gestalt, from a total picture. Because one thing that is crystal clear about the DSM is that although it looks at the individual from issues of abnormal functioning or dysfunctionality or disability or from their inabilities, it takes into consideration all aspects of the individual to arrive at a picture of who the client or consumer is. And once we understand who we're working with, then we can evolve to a place where we can adequately treat the individual. One of the ways we treat the individual, which you will see in next week's lecture, has to do with the more psychopharmacology and making sure that they receive adequate kinds of prescriptions so that they can function adequately. But also there are more psychosocial kinds of treatment that takes into consideration employment, counseling, both individual and group, support services, making sure family members are adequately trained to meet the needs of persons with various forms of mental illnesses, as well as various forms of community resources that are also in place to meet the needs of persons with mental illness. So basically, this concludes your lecture on the DSM. I encourage you to sit with your DSM to further understand its use and to also become more proficient in the use of the DSM as you evolve as a professional.